My name is Erin Trish, and I co-direct the Leonard D. Schaefer Center for Health Policy and Economics at the University of Southern California. The Schaefer Center strives to measurably improve value in health through evidence-based policy solutions, research excellence, and public and private sector engagement. As part of this mission, my colleagues and I have been studying prescription drug markets for over a decade. Prescription drug markets are complicated, and it takes a lot of boxes and arrows to show you even a simplified version of how the dollars and goods flow. While that type of complexity keeps health economists like me in business, it still remains a mystery to most Americans. And we know that where there is mystery, there is margin. Pharmacy benefit managers, or PBMs, which operate in the middle of the pharmaceutical supply chain, play an important role in drug pricing. Historically, PBMs were independent from health plans and added value by reducing prices, encouraging uptake of generics, and expanding the use of mail-order services. However, a wave of consolidation and other activities in the last few years have distorted behavior. Unfortunately, evidence indicates that PBMs are now leveraging their position to extract profits in ways that are detrimental to patients, payers, and the drug innovation ecosystem more broadly. Perhaps one of the most well-studied issues has been the use of rebates. Rebates drive a wedge between a drug's list price and its net price, or the amount the manufacturer actually receives. Schaefer Center research has shown that for every $1 increase in estimated rebates, list prices increased $1.17 between 2015 and 2018. These rebates have grown considerably over the last decade, distorting the market and raising costs for many patients at the pharmacy counter. The incentives are particularly perverse. Beneficiaries pay the most as a share of the net cost of the drug for drugs that face the most competition, where rebates tend to be largest. The ultimate result of these practices is to decrease the effective generosity of insurance by reducing premiums but increasing out-of-pocket costs. Put another way, this system transfers financial resources from sick patients to healthy premium-paying beneficiaries, the opposite of what insurance is supposed to do. Take insulin, for example. Insulin is a highly competitive drug class with rebates typically greater than 50% of the list price. Nonetheless, many patients face high out-of-pocket costs for insulin precisely because list prices are inflated so PBMs can extract large rebates. Schaefer Center research also demonstrates the importance of following the money. My colleagues found that while total expenditures per unit of insulin remained relatively stable from 2014 to 2018, manufacturers are actually getting paid less year over year. Meanwhile, the share of spending captured by PBMs increased 155% over that 5-year period. At this point, less than half of each dollar spent on insulin goes to the manufacturers. Instead, the majority gets siphoned away by distribution system intermediaries, a parasitic loss, if you will. Other examples abound. For one, a 2018 Schaefer Center study found that 23% of prescriptions involved a patient copayment that exceeded the cost of the prescription to the PBM, or a so-called copay clawback. That is, the patient paid too much and the PBM kept the difference. Another, investigations and lawsuits in recent years have illuminated the pervasive practice of spread pricing, where PBMs charge health plans and payers more for a given transaction than what they reimburse to the pharmacy, keeping the spread or difference. For example, a 2018 Ohio auditor report found that PBMs charged the state a spread of more than 31% for generic drugs for its Medicaid plans. And another, in 2020, PBMs extracted $9.5 billion in price concessions, the type we've heard about from the previous two witnesses, from pharmacies on Medicare Part D transactions alone, up over 1,000% from a decade prior. These issues might be less concerning if we believed our current system of pharmaceutical distribution and reimbursement, centered on and orchestrated by PBMs, was working efficiently. Unfortunately, evidence suggests that it is not. When my colleagues and I compared cash prices for common generic drugs at Costco with their cost to the Medicare system, we found that Medicare overpaid on 43% of prescriptions in 2018, totaling $2.6 billion in overspending for the program in that year alone. It is clear that reforms are needed to improve the functioning of the pharmaceutical distribution system and ensure that the system works to benefit patients and drive value. These could include things like increasing transparency, prohibiting tactics that feed off the current complexity, and further investigation to better understand the myriad ways the current system harms consumers and reduces innovation. Thank you, and I look forward to your questions.